Hello guys, welcome to another quick overview. This is a topic we've done again last year. So for me, most it will look like a repetition, but it's an important repetition because a lot of the topics we'll study this year are built on from here. I will keep referring to these slides. So just bear and as we go along, remind yourself of what we learned last year. At the end of these few slides, I want us to remind ourselves what is abnormal uterine bleeding, to remind ourselves about the normal menstrual physiology, and of course to remind ourselves what palm coin stands for, and of course the various causes, investigations, and management of AUB. And if you remember, there is something we discussed called the HPO axis, which is like the software of the human female menstrual cycle. And I remember the cycle has three phases basically, the follicular, ovulatory, and the luteal phase, which coincides with some changes. Whatever is going on in the ovary coincides with some changes in the uterus, proliferation, then there is the ovulatory phase, and there is the secretory phase of the endometrium. Normally, the cycle will last 3 to 5 weeks, last 3 to 7 days, with not more than 80 mLs of blood loss. 30 to 80 mLs is good amount. So this is what I'm talking about in a nutshell. Remember, there are changes to the pituitary hormones, anterior pituitary hormones, FSH, LH. There are changes to the ovarian hormones, which affect the ovary. You can see the changes to the ovary, and mainly the follicle, and the changes to the endometrium shown below there. You cannot escape this cycle in gynecology. So when you're defining abnormal uterine bleeding, basically it's just a deviation from normal menstruation, either frequency, duration, volume, or regularity. And there are some terms which you may find being used. We defined most of them last year. You can refer last year's notes. Commonly these days you'll hear people talking of heavy menstrual bleeding or amenorrhea or irregular menses, but even the other terms are still in use. Palm coin, we talked about it, and palm is the structural causes: polyps, adenomyosis, leiomyomas or fibroids, malignancy or hyperplasia. Non-structural causes, these ones you'll not find them on in the uterus, in the endometrium, coagulopathy, ovulatory dysfunction. Endometrial causes are iatrogenic, like medications, your COCs and everything, and this one not yet classified. You can also classify them based on the age of the patient, and since the reproductive age patients are the mostly affected, the problems they mainly face include fibroids, polyps, contraceptive induced hyperplasia, and to a large extent polycystic ovarian syndrome. For adolescents, always consider an ovulation, but make sure to rule out coagulopathies. An ovulation is the most common in that age group, but you cannot escape if you did not rule out a coagulopathy. Perimenopausal and postmenopausal women, you have to be very careful, and you have to always rule out malignancy. Some time back, people used to say that any bleeding in a postmenopausal woman is cancer of the endometrium or the cervix, unless ruled otherwise. Always have a high index of suspicion. So clinically, you want to take your history when this patient comes, the pattern, what contraceptives has she been using, what other symptoms does she have, Does she have risk factors for any of the conditions we talked about? And the full gynecologic history. Examination from general to pelvic. You must do a pelvic exam with a sterile speculum before doing your digital examination. And of course, an abdominal examination. Rule out masses and growths and tenderness. Differential diagnosis. Of course, always consider any abnormal bleeding. In a woman of reproductive age, you must rule out pregnancy. In a very young girl, you must rule out coagulopathies. In a perimenopausal or postmenopausal woman, you must rule out a malignancy before you go on and make the other differentials. Your tests include the hormonal tests. Mainly you are looking at what could affect the anterior pituitary. So your prolactin, your TSH before you go to the reproductive hormones. You are looking at your full blood count because you want to see how much blood has been lost, your HB. You also want to see if she has platelets, because that be why she's not clotting. Coagulation profile, we've said why. For imaging, you may do other tests, of course, lab tests, based on your differential diagnosis. For imaging, a pelvic ultrasound most of the times will give you the diagnosis or will rule out the important differentials. Now, these other ones depend on the age and the suspected pathology. For example, endometrial sampling is highly recommended in women past the 4th decade when you're trying to rule out endometrial hyperplasia or endometrial malignancy. Hysteroscopy now comes when you are suspecting endometrial disorders, endometrial polyps, small fibroids, and it may just be diagnostic or it may be diagnostic and therapeutic where you come out with the pathology. Management will largely depend on the cause. And since we may be looking at different causes, different etiologies in later lectures, I will just touch on basics. So when it's hormonal, you may want to counter that with either oral contraceptives, progestins, or IUDs containing progestins. There are non-hormonal treatments like non-steroidal anti-inflammatory drugs, which interfere with them. The thromboxane and PA ratio favoring coagulation. Tranexamic acid, remember this is a coagulopathic agent. Iron to replace, of course, what iron is lost. Surgical management, where indicated, may include ablation, polypectomy, myomectomy, hysterectomy if indicated. And this, I say, depends on the cause. Now, there are special considerations, of course. And for adolescents, when it's an ovulation and you've ruled out coagulopathy, you may do conservative management where you assure the patient that with the subsequent pituitary maturity, the cycle will get better before you put on maybe contra hormonal treatment. For perimenopausal, have a high index of suspicion, and for the postmenopausal for malignancies, mainly CA endometrium and CA cervix. You can look at this case in groups or alone to help bring out what we talked about in this lecture and last year. So to summarize, a reminder is that AUB is common. It may make up even up to 25% of the gynecologic consults. Palm coin classification, do not forget when you are rolling out what is the cause. Thorough history, examination, and investigations are key, and management will depend on cause and the patient preference, of course, and severity of your symptoms. Thank you.